Please note, today's session is being recorded. If you have any objections, you may disconnect at this time. Thank you very much. On behalf of the National Cancer Institute, I wish to welcome everyone to today's Implementation Science webinar. We are excited to be joined by our speakers, but before we get started, a brief word about logistics. We ask that if you are not already on mute, to please keep your phone on mute for the duration of today's presentation. As mentioned, the session is being recorded and muting all lines will help us to avoid any background noise. We encourage questions. They can be submitted by using the Q&A feature on the right-hand side of your screen. Please type your question in the provided Q&A field and hit submit. Do submit your questions at any time during today's call. And with that, I will turn it over to David.
Thank you very much. And let me add my welcome. You can see that we have three wonderful speakers with us today, Sarah Coburn, Terry Malo, and Dan Ruland. The latter two from UNC, Sarah, of course, with us here at the NCI. And what we've been trying to do across the last few months is to think about the intersection between some of the specific initiatives that we've been able to support out of the Cancer Moonshot and the broader implementation science community. So if you've been with us in the past with some of these sort of hybrid presentations and fireside chats, we've really been trying to engage you and get a sense of what would help you to understand both what's going on in these different initiatives, but also how they map onto some of the broader work that you're all doing. It's been a busy week for us already. Yesterday, some of you joined us for a different series that was focusing on policy and implementation science. But back here, we're really thinking about all that we can try and accomplish through the Cancer Moonshot. Of course, the initial effort was to try and say, how do we more rapidly advance the science, implementation science being one of the key areas under the moonshot that we wanted to focus on. And certainly this concept of accelerating colorectal cancer screening, follow-up, and referral to care through implementation science is front and center in terms of our efforts as a sort of tracer through which we can think better about the evidence base, about the interventions that are effective but not necessarily delivered as well as they should be, and how we really try and reach traditionally underserved populations. So with that as the prelude, what we wanted to do is turn things over to Terry, who's going to kick off with a bit of an orientation to ACCESS, and then we'll be able to both pull in your questions, which we know will be wonderful as always, as well as some of the thoughts of our distinguished panel. So with that, let me turn it over to Terry and take it away.
All right, thank you. Thank you for that introduction, and thank you all for joining this discussion about the ACCESS program today. Just to set the stage for our discussion and kind of by way of background, colorectal cancer remains a leading cause of cancer deaths among men and women in the United States. And this is despite the availability of several screening modalities that can detect cancer early and reduce CRC mortality rates. CRC screening is underused, and it's particularly underused among vulnerable populations. And just to emphasize this point, in 2018, the CRC screening rates among U.S. adults aged 50 to 75 years was about 69% nationally, but among patients served by our nation's health centers, the screening rate was only 44%. And these health centers tend to serve patients residing in rural areas. They serve racial and ethnic minority populations and low-income populations. So in other words, traditionally vulnerable and underserved populations. And both of these rates are well below the goal set forth by the National Colorectal Cancer Roundtable, which is 80% in every community. To increase CRC screening rates, researchers have developed a number of evidence-based interventions designed to promote screening uptake, including 22 interventions in the NCI's Evidence-Based Cancer Control Programs database alone, and this database used to be called RTIPS. And these interventions have been developed to increase screening rates for many target populations, including different racial and ethnic populations, low income and rural populations. They've used a variety of delivery modes, such as mailed brochures and patient navigation, and they've been implemented across a variety of delivery settings, such as community-based organizations and clinical care. And they've used different implementation strategies, including technical assistance, training, champions, learning collaboratives, and audit and feedback. But these efforts have often focused on developing and testing single-level interventions that target change at the patient level, the provider level, the clinic, or the community level. But these single-level interventions are often insufficient to lead to sustained change in CRC screening, follow-up, and referral to care rates. To have a significant impact on reducing CRC-related mortality, we need more multi-level interventions that address change at least 2 levels. So with that background in mind, I'll talk about the Cancer Moonshot, which was designed to accelerate efforts to prevent, diagnose, and treat cancer and achieve 10 years of progress in just 5 years. In 2016, NCI convened the Blue Ribbon Panel to provide recommendations for achieving the Cancer Moonshot's ambitious goal. And in their final report, the Blue Ribbon Panel highlighted that substantial progress has been made in identifying interventions that are effective for CRC screening, but we've experienced barriers to large-scale implementation of these strategies that have prevented widespread adoption. And the panel highlighted that we need additional implementation research to accelerate the development and testing of effective strategies to achieve wider adoption of evidence-based approaches, especially among underserved populations. So the goal of ACCESS is to promote research in CRC screening, follow-up on abnormal results, and referral to care among populations that have low CRC screening rates, particularly underserved groups, including racial and ethnic minority populations and people living in rural or difficult-to-reach areas. And one way in which ACCESS is unique is that it's not only focused on areas with low CRC screening rates, but also the shared characteristics in localities or pockets of the localities that serve as barriers to and facilitators of CRC screening. And through ACCESS, we want to better understand the shared characteristics that have contributed to CRC screening rates staying low and identify the strengths of these pockets that we can leverage. So the ACCESS research projects were funded by a UG3-UH3 phase mechanism. The first year was a planning and exploratory phase during which the investigative teams pilot tested and refined a multi-level intervention, and then a 4-year implementation phase during which the investigators currently are testing the impact of their multi-level intervention on increasing rates of CRC screening, follow-up, and referral to care. There are a total of 5 ACCESS research projects, and all projects are focused on populations with CRC screening disparities. So 3 projects were funded in 2018, and they're shown here. ACCESS Appalachia is focused on 12 counties in Appalachian, Kentucky, and Ohio. And then ACCESS Chicago and ACCESS North Carolina are both focused on low-income and racial and ethnic minority populations in Chicago, Illinois for ACCESS Chicago, and then 2 regions in North Carolina for ACCESS North Carolina. And then 2 research projects joined the ACCESS Consortium last year. ACCESS Oregon is focused on a rural Medicaid population in Oregon, and ACCESS San Diego is focused on medically underserved populations in San Diego County, California. And then RTI International is the ACCESS Coordinating Center, and RTI supports the organizational, administrative, and scientific activities for the ACCESS program and coordinates trans-program activities, some of which I'll talk about in just a moment. And there are 2 scientific collaborators at NCI, Drs. Sarah Coburn and Wynn Norton, who are substantially involved in the ACCESS program in their roles as project scientists. So this map highlights the breadth and geography of the ACCESS program. And I've mentioned that the ACCESS research projects are working with populations with low CRC screening rates and addressing cancer health disparities and implementing multi-level interventions. I wanted to add that they're also conducting hybrid effectiveness implementation studies. So the projects are measuring and assessing both effectiveness and implementation outcomes. The last thing I wanted to touch on before we move to our discussion is trans-ACCESS collaboration and contributions to implementation science. And one area in which we're aiming to contribute to the field is by creating high-quality data and evidence about the implementation of interventions to improve CRC screening, follow-up, and referral to care in multiple settings. The data and findings will be available to the public, and in addition to the unique data points that each project will generate, we'll also have common data elements that will be collected across all 5 research projects. And those common data elements include effectiveness outcomes, implementation outcomes, and cost-effectiveness data. And another area in which we're aiming to contribute to the field is through evaluation of implementation across multiple settings and learning about differences across settings and by setting. Our consortium is still fairly young, but we're starting to work on trans-axis research projects that leverage the rich data collected by the individual projects. And we're still kind of working on prioritizing the research topics. And one emerging area is COVID-19, probably not surprisingly. We're starting to think about things like which implementation strategies have been adaptable in the context of COVID-19 and which strategies have not, and what key adaptations have been implemented to address challenges posed by the pandemic. So I'll wrap up by saying that we think that the whole of the Access Consortium is greater than the sum of its parts, and together I think we're well positioned to meet the Cancer Moonshot goal to achieve 10 years of progress in just 5 years, and we're looking forward to sharing what we learn. So with that, I'll stop here and we can transition to the discussion. Thank you.
Great. Thanks so much for that. And again, a gentle nudge for any questions that are popping up to get them in so that we can take advantage of that. You'll see in front of you a lovely fireside representing the fireside chat nature of what we're now shifting into. And so while you're thinking about those questions, and by the way, just to say we appreciate absolutely our experts who have joined us, but as you learned, there's a much larger group of folks across the country and certainly at the NCI. Sarah just noted that there are additional NCI project scientists in the chat, Robin Vanderpool and Michael Halpern, and so we're grateful for everybody's contributions to this. But did want to sort of start out while you're thinking about additional questions to just get a sense, and we do these on our fireside chat, just get a sense of what each of your entry points was to be thinking about colorectal cancer screening, and certainly to be thinking about it in the context of how do we improve implementation science toward the betterment of screening, of follow-up, of referral to care. Maybe I'll go and I'm just looking at the pictures in front of me. Maybe I'll go Dan and then Terry and then Sarah in that order to just say a little bit about how did you get into this area and anything else you want to share.
Thank you. Thanks, David. And great overview, Terry. Absolutely. Yeah. I mean, how did I get to CRC screening? The shortest answer is through my mentors, as often happens in this kind of science. But the folks ahead of me, Russ Harris, David Ranzerhoff, Mike Pignone here at UNC, were working in colorectal cancer screening, Bob Sandler for a while. And I kind of came along mid-career as a clinician who wanted to look at certain disparities. I was particularly interested in Spanish-speaking Latino populations. I teamed up with Mike Pignone, who, and this was several years ago, said, for your career award, he had been doing some trials in decision aids, giving patients more clear idea that they could choose stool-based testing or colonoscopy, so that was the decision support. And he said, we don't have this in Spanish. And so I sort of did a adaptation of that for colorectal cancer and ended up testing it in a trial. And, from there on, I've just been very interested in it as a public health problem, as a paradigm for implementation. And of course, we know that once you get beyond your sort of test tube of we were testing the decision aid in Spanish speakers, but when you go to the real world and implement, they're like, well, we don't want to just do something for Spanish speakers. By the same token, when you go there, they don't say, well, you only have it in English. In most federally qualified health centers, which is a lot of our target, they're saying you got to bring it in Spanish too. So that was a long answer to just say, I think I came to it with an interest in clinical medicine, public health, delivery of preventive services, and equity. So that's how I came here.
Great, thanks, Terry.
Yeah, I had started my career in cancer prevention and control with a focus on HPV vaccination, and for almost 10 years, I studied ways to improve HPV vaccine uptake and help physicians and other clinicians make effective HPV vaccine recommendations for their patients. And then it was probably just over 3 years ago, I saw this opportunity to work with Dan and his team on colorectal cancer screening research. And I was excited about the opportunity to expand my research portfolio to another type of cancer, a different patient population, and different research methods. And I also have a family history of colorectal cancer, so the topic was important to me. And during these past 3 years, I've also had an opportunity to pursue my interest in implementation science. I participated in the TIDRC training in 2018, and now with ACCESS, it's really neat that I'm able to combine those interests in CRC screening and implementation science.
Great, thanks, Terry. And Sarah.
Thanks, David. I'm actually going to follow in both Dan and Terry's footsteps more than one might expect, so I'm going to answer for myself and then also for my NCI self. So I also trained at UNC, which means that I had the privilege as a student of working on projects that Russ Harris was PI for and working with David Ransohoff and Mike Pignoni as well. He was just an intern or fellow or something when I first started at UNC. So I've been thinking about CRC screening and cancer screening more generally for a long time, since I was a doctoral student. And then from the time that I came to NCI, Terry described in the opening in the slides this trajectory of cancer screening research that's gone from individual level focus to multi-level and now to pulling in the tools of implementation science. And I have lived that at NCI. When I first came, we were still confirming that information was not enough to get individuals to change their behaviors. And doing work, bringing in the physicians was relatively innovative. So we've come a long way from those individual level focused interventions to recognizing that how much the context matters. And then, really with the impetus, as you know, of the Cancer Moonshot Initiative, it singled out the need to take the strong evidence of the success of colorectal cancer screening tests with the science of implementation and figuring out how to do it. And the piece in between is the work that I've been doing at NCI, which is the generating and studying interventions and identifying those that have evidence of effectiveness. So what we're doing with ACCESS is pulling all those pieces together, saying, let's take the evidence-based interventions that we have, multi-level, individual level. Let's take cancer screening, which we know works for colorectal cancer, and develop strategies to figure out how we go about implementing these things. And just to bring it up to the most important level, let's choose populations in greatest need, so that we're advancing implementation science, healthcare delivery research, and also having the biggest public health impact that we can, as Terry said, as quickly as possible.
So thanks for that, all of you providing that broader context over time in terms of your interests. And now we're starting to see these wonderful questions pop up. So want to make sure that we get to as many of them as we possibly can. The first one actually is a nice dovetail with what we just heard. So it says that colorectal cancer screening is low in racial ethnic minorities and also rural areas. How do we assess which interventions may work for which setting? Who wants to kick that one off?
I think that's one of the essential questions of implementation science, is to take an intervention that worked somewhere. And by worked, we mean there was evidence of its effectiveness with a population in a setting, and then start using different strategies for adapting and measuring the success of that. So did the adaptation work and produce behavior change, in this case, increased screening? That's two different measures, right? Whether we increase screening, but also the implementation question of whether the adaptation had the effect of making the intervention more suitable for a particular new population. I think that is the work.
Yeah, I agree. I mean, I think that is sort of at the core of the ACCESS Implementation Science Initiative, and there will be interventions that work generally across things, but almost, I won't even say almost inevitably adaptation is required. The U.S. healthcare delivery context is very heterogeneous. We have one nation, and sometimes we have 50 nations, as we all well know, and we have just a variety of contexts and populations, and I think the closer you get to the partnerships in the ground, you do also develop a sense of what can work and what will work, and the ability to actually partner is, I think, a key to figuring that out, right? I mean, you don't just walk into a community health center in urban south side of Chicago, drop the JAMA article with the recommendations of colon cancer screening, say, there it is, go ahead. Obviously, there's a whole lot more that goes into it.
And it sounds like, again, from what Terry had presented, one of the benefits of seeing these as hybrid studies where you have your effectiveness aim and your implementation aim is that you don't have to take it for granted that this is going to work, but rather you're taking the time to try and understand what does that fit look like and for whom are these different modalities effective and then for whom are these implementation strategies effective. Terry, did I get that right?
Yeah, I think that's exactly right.
Okay, cool. So I'm seeing and awesome questions coming in. Next one asks about the Access centers broadly. So are the Access centers clinic-based? And the follow-up question being, how do we reach individuals that aren't part of any clinic system but need colorectal cancer screening? Has the panel been able to get state records, registries for eligible individuals? Sarah, I wonder if you wanted to just talk about the broad makeup of the different centers.
Yeah, sure. So Access centers, as you heard from Dan and Terry, are like Chicago, for example, is working within the University of Chicago system. So they're one EHR, they're not one clinic. But when we wrote the application, the announcement, we really specifically required that the interventions or the strategies that are being tested to implement CRC screening not be based in a single healthcare delivery setting. For exactly that reason, we wanted to reach a pocket of people whose screening rates were low and not necessarily only those people in that pocket who also had good health care. So there's a variety of different types of settings. The people in San Diego are working with a hub and spoke model where they have an outreach system to many different populations who are engaged in different clinics. Sorry for the background noise.
But I think you just went on mute. So
that I could let my coworkers know to make less noise in the kitchen.
Gotcha. Okay, seamless.
Yeah. So I'm not sure I have a lot more to answer that anyway. The different projects are taking different perspectives using different data sources. Some are using electronic health records data, but as Terry mentioned, also the folks in Oregon are using Medicaid records. So we are definitely trying to avoid that problem of only seeking to bring care to people who already have access to it.
Gotcha. Terry or Dan? Oh, yeah. Dan, you want to jump in?
Oh, I was just going to say, it's funny, there's a bit of a continuum on usual source of care. This idea that it's binary actually, as we know, isn't true. There's churning in insuredness and in Medicaid. And interestingly, the intervention that are the North Carolina project, and I think 3 or 4 of the other ones, includes mailed fit outreach. And one of the ideas of that is simply that whether people are attached to a clinic or a federally qualified health center or not isn't just a switch. I mean, sometimes they just don't come in very often. So these are ways to reach people who may come in infrequently, or they only come in when they're really sick, and then cancer screening is just way down the priority list. Admittedly, there are pockets where it's just really hard to reach people who have zero access, no access. But I definitely think there is a sense that we want to make this broader than just, wow, this worked in one health system. So.
I just wanted to add that I think that some of the research projects are also, they also have interventions at the community or system level, and I think Access Appalachia is looking into, offering education and awareness, seminars and maybe health fairs or, having these inflatable colon events. And it just, I think part of it is though that, they're working with their clinical partners to kind of determine what they think would be most effective for their communities.
Great, thanks. And of course, there's sort of affiliated projects that are focusing on work between cancer centers and American Indian populations as well. So really trying to drive home the importance of understanding context. And it sounds like at the heart of it are the partnerships that are developed to really try and understand what might be most helpful for different populations in different circumstances. Is that fair? Okay.
It's actually more than fair because we are trying to bring some more of the science of community-based participatory research to understanding what are the hypotheses that we have about how those partnerships actually enable, whether it's through adaptation, through participation, through trust. How does that work to bring about both the implementation and the effectiveness outcomes?
Great, thanks. So something that I think picks up on what Dan was just saying and is the next question, and that's, there's the fit kits. There's also just the broader context of COVID. And so the next question really asks, are there opportunities to expand screening efforts via at-home fit kits, especially considering COVID-19 challenges? But I want to make that maybe a little bit broader and just to say, how is COVID as this incredible backdrop for everything that we're doing influencing how you're thinking about the projects and how you're thinking about colorectal cancer screening overall? Anyone want to start with that one?
Terry, you want to tee that up? Or?
Yeah, I think COVID has definitely thrown a wrench in our plans just across the research projects. I meet monthly with members of the other research projects and kind of start off the meetings with how are things going, and it sounds like lots of different challenges. One of the challenges that I can speak to as far as Access North Carolina and maybe a couple of other projects are, so we are doing mailed fit outreach, and that's something that we had kind of planned from the start, to try to reach people who aren't able to come in, as Dan said, and just to increase access to screening. But one of the wrenches that COVID threw into those plans is that, some of the endoscopy, actually, I think all of the endoscopy centers in our area, they were limiting their procedures. And so we didn't feel comfortable mailing out hundreds or thousands of fit kits without, patients able to get the follow-up care that they needed in a timely manner. So, that was tricky, but at the same time, our clinical partners, they were just so their plates were overflowing, trying to tackle COVID, and really, I think not just our partners, but sort of nationwide preventive care kind of took a back seat to COVID. And so we wanted, as researchers and people who didn't have those clinical responsibilities, we wanted to do what we could to help people get screened during this time. And mailed fit is especially nice because you don't need a clinic visit. And so that overcomes some of the barriers that people have, not wanting to go to a facility, to go to a clinic. But at the same time, it was just a little bit tricky, and trying to navigate that and making sure that we weren't sort of introducing problems by, mailing people fit kits and then they weren't able to get the care that they needed as quickly as they needed.
Sarah, you were?
Yeah, I think I would add that in addition to those challenges and the interruption of clinic flow and so on, we've been trying to take advantage of this interruption in a couple of ways. One is to say, well, if our purpose is to reach people who can be challenging to reach, maybe there are opportunities here to test new approaches that in the long run could turn out to be better. So, for example, the Access Oregon group changed what had been planned for an in-person training, a couple of days, intensive in-person training with collaborators in their local, with their colleagues in the different areas. They changed it to a remote training and discovered that it worked really well, that they got good engagement from people, good feedback from people, good excitement generated. And so that may turn out to be a more sustainable model for doing that training going forward anyway. So that's a way to learn scientifically. And the other is that we are about understanding in some of the delivery systems what makes them more amenable to change, more adaptable. And you could argue this is the biggest adaptation they've been asked to handle in a long time. So again, from a scientific perspective, trying to understand which are the systems, which are the clinics, which are the ways of practicing that have been best able to get back to work, even with this big disruption.
Oh, I think, there's so much to say about this. I do see a comment, which is, I think, relevant here, which is about the COVID testing and the quarantine requirements before colonoscopy posing a barrier, particularly for the low-income patients who can't telework while quarantining before the procedure. We're definitely starting to see that, as if colorectal cancer screening weren't hard enough, we've now thrown yet one more barrier, one more step in the process that is differentially difficult for people who work outside the home versus not. Our intervention not only includes, for our project, not only includes the mailed fit, but navigation and really having someone on the front line, on the telephone mostly, trying to help patients get through these things. And so I'm glad it was Emily Perez Alejo raised that, because I think it's something we're thinking about now. I don't have a great solution to it other than maybe with navigation and really some creativity, you could do things like, well, if you work Monday through Friday and you have to work in person, how about we get you COVID tested on a Friday, quarantine for the weekend, try to at least mitigate some of these impacts, whereas for other people that might not be necessary. So really, yeah, there's lots going on, and COVID has introduced challenges, although a few silver linings too, as Sarah pointed out. There's some things that we were actually learning that we wanted to learn a long time ago, and we're now learning much faster.
I would also, something else that came to mind is I think that people may be becoming more accustomed to sort of telemedicine and doing at-home screening or sort of getting remote care. And so I wonder if this is just an opportunity also to learn. I think it's still a little bit too early, at least for the Access North Carolina project, but I do wonder if we're going to see some increases in fit completion over our, what we found in our pilot study. It'll be interesting to see.
So there's another question along the same line, which I think just basically asks, are you thinking differently about how you're measuring success of the screening efforts during the pandemic? Has it changed any way, either the question, the outcomes that you're looking for, or is it more that this has nicely woven into the overarching questions that you're seeking to answer?
Mm-hmm. It's a tough one. I mean, I think mostly the latter. That it's implementation science is so much about context and understanding context as a modifier, and how we can add yet another modifier to make that sort of interaction term work better, right? But I don't know if others have thoughts about how we've changed measurement. I don't think we've changed a lot. There are definitely things that we're trying to assess more directly about telehealth, and we've started to really ask very explicitly about adaptations to COVID. But I don't know. Others?
Yeah, I was going to say the same thing, that we've added some new measurement. Our coordinating center, RTI, has developed a little mini frequent survey and has been trying to track, more than we ever imagined would be relevant, the ebbs and flows of the impact of the pandemic on screening. But I think, like Dan said, that's the context, and our whole point is to be able to accommodate context. So no, I don't think it changes the main outcomes, either implementation outcomes or efficacy outcomes.
So a question on a different front, and that's we certainly have folks who are attending this particular session and our other sessions from around the world. And so we do have a question about were there any colorectal cancer screening programs done or being that you know of or that you've been involved in that are being implemented in countries outside the U.S.? Do you see challenges or similarities in terms of the work that you've been doing in the U.S. in terms of trying to optimize colorectal cancer screening with efforts to try and set up such programs in other countries? Anything about the kind of global relationship of the work that you're doing and any experiences to draw upon?
I participated in the International Cancer Screening Network and also the specific colorectal subgroup of that. And I would say that it's fascinating from a scientific perspective to see that even when you remove the many access barriers that we describe as being present in the U.S., that, in the Western anyway, in the organized medical Western countries that are more equivalent to ours but have universal health care, they have very similar barriers in terms of people's understanding of colorectal cancer, their fear or embarrassment or worries about the testing. So even when they have the access, they still have similar barriers to Americans in the uptake of screening. I don't know.
I agree with that. I think, the behaviors that are required to successfully screen for colorectal cancer now are not behaviors that most people like to engage in. So when we have a blood test finally or something simpler, I imagine rates will go up dramatically. I know that another observation, and others I'm sure know this, that the U.S. is, I won't say an outlier, but we definitely have a much more colonoscopy-oriented screening program, if you could even call it a program, than other nations. And Canada, for example, recommends stool-based testing, and Great Britain and Australia, I know, focus more on stool-based testing as the initial test. But, I don't have deep knowledge, and I think there's always this question, at least in my mind, of countries in transition or developing countries, and where does cancer screening or colorectal cancer screening fit in that priority list. A couple of years back, we were starting to get really interested in working in Puerto Rico on a project, and then hurricanes happened, and it just sort of, I think, like COVID, it sort of has fallen down, and we'd like to find ways to bring that back, but it has to fit in the resources and that context and the priorities for the country.
Great. So I wanted to, there's another question that I think picks up on something that Terry had introduced as part of the framing, and thinking about these things as multi-level interventions and the success of prior studies that really focused on one, but then it brings together this complexity, and that's this continued struggle, as the questioner asks, in defining what components of an intervention are part of this multi-level intervention versus which are part of an implementation strategy. Giving the example of audit and feedback, is that part of a multi-level intervention, or is that an implementation strategy that is put to work to try and help implement that intervention? How do you deal with this challenge of trying to parse between that sort of health intervention that may be multi-level and the implementation strategy? Anyone want to take that one?
So I would say that there's no objective truth to whether a particular approach to change is being used as an intervention or used as an implementation strategy. I think the question is what outcome you're measuring and for what purpose you're using it. If it already has an evidence basis and you're measuring the effectiveness of it, then you're using it as an intervention. If you're using one such thing, it's a single level, and if you're using it as part of a package where you're considering the influences, say audit and feedback, but you're intervening only with the physicians, but you're also measuring the impact some way on other clinicians in the practice, or on the way the EHR system is integrated, or so if you intervene at one level and measure at multiple levels, and you're doing multiple levels, and if you're instead testing audit and feedback as part of a set of evidence-based interventions that comprise a strategy for implementation, then you should be measuring implementation outcomes and looking to see how effective your implementation outcomes are. So there's no, it depends on the context of how you're using it.
And as you said, sort of, if it seems like this is intended to change an implementation outcome, then you consider it in that strategy bucket. If it's intended to have a direct impact on a health outcome, it sounds like what that sort of feeds more into the intervention that you're trying to implement. Yeah.
And if you didn't have any evidence that it was going to change the health outcome, you wouldn't yet be integrating it into a package of evidence-based interventions to make a strategy, because you first need to test the effectiveness.
Mm-hmm. So you'll see that the slide has changed. That means it's yet another reminder, which you don't really need to submit your questions, because they're coming fast and furious and they're awesome, but also this lovely stove that you get to see in front of you. So thanks, as always, to Sarah for finding that art that we can use. We now shifting gears, there is a question, and it popped up before, about adaptations. So thinking about adaptations and reflecting on the different projects, can you reflect on ways that the initiative has sought to document the adaptations realistically and pragmatically? So how are you dealing with the idea that there is variation in terms of how the interventions are being delivered, and how do you track that?
I see that the question is from Borshika Rabin. Thank you, Borshika. She's actually part of the implementation, the interventions and strategies work group. That's one of the work groups as part of Access. So I think she's wanted to highlight some of our work in trying to capture adaptations. And we actually last Tuesday, we had a webinar as part of our Access Consortium. We invited Dr. Shannon Wilsey-Storman to talk with us about how she's used FRAME and how we might be able to adapt that and use it to study adaptations across our Access research projects. And it's been we've had quite a lot of discussion around, a tool that we might be able to develop as part of the Access Consortium. And is there a tool that we can use to kind of systematically capture across the research projects that isn't too burdensome? For those of you who have seen FRAME, it's very comprehensive. And if, are there different, is there kind of like a condensed version of the FRAME that we can use that won't take up too much time, especially working with these clinical partners during COVID? Is there a way to capture adaptations in a way that, maybe we could use 3 questions, and for those of the projects who have a little bit more bandwidth or resources, maybe we can have like an expanded tool. So that's something we're still working on, trying to come up with a tool that we could use across the projects. But definitely has been on our mind for the past, I think, year or so.
Great, thanks for that, and thanks certainly, Borshika, for the prompt. Maybe it's a prompt, I'm not looking at who's submitting these questions, but a good question nonetheless. And that's really thinking about sustainability and how within the initiative you're thinking about sustainability. How is it assessed? What time frame, which is often a challenge for people to try and think about, do you all consider adequate? And are there any practical examples where you would be able to say funding ended and then we can see that the interventions were sustained, the outcomes associated with them were sustained? So how within Access are you thinking about sustainability?
Sarah, do you want to say anything broadly about Access, or do you want, I can talk mostly about North Carolina, but.
Well, let's start there.
Okay.
Yeah, I think as I look across the consortium at some of the projects, some of them are building implementation on a pretty solid foundation of some good, shall we say, infrastructure at the state level, whether it's the Oregon Medicaid ACOs or the hub and spokes. They've got some good infrastructure crossing health centers, federally qualified health centers into San Diego. North Carolina is less so. I think we went into this knowing that what we wanted to do was try to take a fragmented system, so lots of FQHCs, but they really operate independently, and demonstrate that in a couple of different contexts, this mailed fit, centralizing it, would work. And it could be done, and it could be effective. And I think we're that far. We had envisioned, it's a challenge. This is a long answer to it's going to be hard, but we had thought the Community Health Center Association in North Carolina was going to be, a real rising hub for this. It hasn't gone that way so far. On the flip side, infrastructure at the state level and DHHS and American Cancer Society have really built up some great infrastructure in North Carolina. And we got one of those CRC-CP grants in our DHHS here. So I think we are always thinking about how are we going to sustain this once we've demonstrated it, and we're constantly talking about that. But I think that the trick is hopefully that you think about this all along a project and you don't sort of say, okay, we're done, we analyzed the data, here's the paper, the project's over. Wait, how do we keep this going? And so it's a work in progress for us, but maybe others can also shed their ideas on this.
The only thing I would add to that is that, we recognize the challenge, this challenge from the beginning, David, of course, and you and Wynn and I were writing the announcement, so that there was asked to be an eye to having the project sustained even in the writing of the grant applications. And Terry highlighted this idea of building on both the strengths and the challenges in the communities that the projects are taking place in. And the hope was that by building on those existing strengths, that there'd be a higher probability of them being able to sustain. So.
Great. Thanks for that. So seeing that we have a number of questions, feel free to keep them coming as you like, but we're shifting into a little bit more of a rapid question and response. So maybe this goes to the first person who wants to jump in, and thank you in advance for your bravery. So this one is ripped right from the headlines because many folks have seen that the U.S. Preventive Services Task Force has issued language that is being open for comment right now. The potential change in CRC screening recommendations from age 50 to 45. What are some lessons learned from your programs to reach the population who might become eligible for screening, and what challenges do you anticipate? Anyone want to jump in on that one?
Sure.
Okay.
I think we kind of knew this was coming, but there has been even some email and some buzz about this in our research program and across the steering committee and the consortium about this issue. And we're definitely going to be addressing it and thinking it through and at the steering committee meeting in a week and a half or so. And I think we definitely have wanted to lean into that, even knowing we knew this was going to come out in North Carolina. And I think we would like to, if we can get our partners to agree, and I think they will, test a sort of a separate strata of outreach to the 45 to 49-year-olds. And, one thing I like about pragmatic and implementation research is that you don't have to chisel your protocol in stone and say, oh, we can't change this for 5 years, when in fact, in the real world, that's not how things are implemented, and clinics and people pivot as COVID's happen and as guidelines change and things. So we're trying to find a way to look at that, but it is a slightly different set of questions. I think an expanded guideline to a new population, and maybe how we can help these clinics, move more quickly than they might have if it was just, the guidelines change, and then a year later the UDS measures change, and then, sort of the slower uptake. Those are my thoughts on it as of today.
You also mentioned, Dan, in an email today that I saw some of the practical issues about making an adaptation today, right? Who's going to pay for it? Where does the reimbursement come from? It's not just UDS measures, but it's the rapid realities of adding this new population. What would that mean for the clinics we collaborate with?
Right. Our partners in North Carolina, and maybe there are other clinical experts and policy experts out there, but have, a lot of them have said, look, if you have an abnormal FIT test, there are very few payers, I think, who are going to deny payment for the follow-up colonoscopy. Of course, we also have the uninsured to deal with. So there are lots of issues around just because a guideline changes on this date that you can just turn it around and implement it. But in some ways, that's what's great about having the resources of this consortium is that we can, when these things come up, we can study them, because the clinics themselves and the populations themselves don't have the bandwidth to sort of produce a picture that might inform science the way I think we can. So.
Mm-hmm. Great. So there was another comment here that was just focusing on novel ways of trying to conduct some outreach even beyond just the health system. And so the note of trying to recruit patients via food bank and pantry sites. And I guess I was curious, within the various projects, are there other examples of sort of non-healthcare related ways that you've been trying to extend outreach and engagement within the different projects?
I know both. Terry mentioned that the Appalachian Group is doing posters in community areas. They're also doing community surveys that are totally disconnected from participation in any clinic. And then San Diego, I think, also is using some kind of media that reaches around the county that is different, not clinic-based. I'm not sure exactly what their approach is.
Mm-hmm. Okay, but innovation abounds. Another question, what level of engagement do you need from clinics? And is there any IT infrastructure that's needed from clinical partners with the challenge that in some cases there might be limited resources across the board?
That's huge, right? I mean, and I think because we've been doing this for a long time, we kind of knew that going in, and you sort of need clinical implementation partners, but sometimes the infrastructure around the data and the IT isn't exactly the same people, and you need to find who those people are in any of these health systems, because without the ability to run queries and find out who's eligible for screening and tweak those, it's hard to move forward or to create reminders or whatever your intervention is, at least at the clinic level. So yes, the partnerships and engagement have to be strong, and you have to have a good relationship with the IT person, and yes, also I do think that's actually a limited resource in many, a structural limitation and a resource limitation for many of these populations is that where they go for their healthcare, there just isn't as much IT support, that the systems just aren't as strong and well developed as they are, let's say, in these large integrated health systems. So it's a challenge. It's not just like nursing or physicians. It's also someone who can help leverage the data for population health. So it's a struggle.
Mm-hmm. So 3 more questions that I want to try and get to, and then we'll have to close things down in front of this lovely virtual fireplace with guitar to the side. Just wanted to point that out because that's what I see. How does this program interface with or collaborate with the CDC colorectal cancer control programs that, while not a research program, has similar goals in terms of the implementation of colorectal cancer screening? Any idea, the crosswalk with some of our CDC colleagues and projects?
So we certainly, go ahead, Terry, is that you? Go.
Go ahead, Sarah.
Okay, I was going to say we certainly stay in good communication with our CDC colleagues. We invite them to planning meetings, and when we have in-person meetings and people are allowed to travel, we've had visitors from CDC. So we do communication back and forth for sure, but I would argue that what they're doing is implementing, not studying implementation. So they take evidence-based programs and try to deliver services, and what we're doing is trying to study how, exactly as you said in the question, we're doing research, they aren't. So they're trying to take evidence-based implementation strategies to bring colorectal cancer screening to communities across the U.S. They need to build on what we do, and we need to hear from them what they need to know. So that's why we stay in good communication, but the projects are not really integrated. Beyond that would be my view.
And then we have other bridges. So folks may know about the CPCRN, the Cancer Prevention Control Research Network, which is a nice long time effort with NCI and the CDC working together. And one of their key areas of focus for years has really been on cancer screening. And so trying to build those different bridges, but also recognize that these different initiatives may have more specific outcomes that each is required to try and generate. And how do we do better as we try and do? Next question, do you have specific advice for overcoming provider and or hospital preference for colonoscopy over mailed fecal testing? First one to jump in.
I think it's more than provider preference. It's development, the way the systems are built and the way reimbursement is structured. It's hard to get a system that's designed to have, X hundred colonoscopies ordered per year to recognize or to adapt to. It's not a question of recognition. It's a question of structural change. People who get paid one way can't just decide to go another way. Their whole system won't be able to function. So I think we are learning about how the structures of care delivery systems enable those changes, what the barriers are, but I don't have an answer right now.
Okay, thanks. But certainly understanding what are the specific influences that have led to that preference and trying to understand what is potentially changeable. And thanks. Oh, sorry, go ahead, Dan.
I was just going to say, I think that the evidence reviews that in the task force puts out, both the new one and the old one, are pretty nice at sort of showing the trade-offs you get at the population level, certainly with a mailed fit or a fit-based program versus colonoscopy, in terms of they don't really do costs because they're not allowed to, but you know, as number of colonoscopies or complications as a proxy for the harms and costs of a colonoscopy program, as opposed to what you get when you start with fit. But I think they're coming around. I think generally I feel like society is coming around to offering choices more, but it is still an issue, and it's still underpinned by differences in how people get paid. And I just want to also answer that prior question with North Carolina, the CRCCP, and I don't know how it's played out in other states, but we encouraged and partnered with our state, DHHS, to apply for the CDC funding because, as Sarah said, it's implementation. And we said, we'll be technical assistants. We know a lot about some of the specifics and evaluation, but, you know, we want you to drive the state level public health approach to this, and we'll provide expertise as needed. So I hope that turns into a good partnership. I think it will.
Yeah, no, thanks for that. And just on the subject of several of the things that have been mentioned, you'll see in the chat that Wynn had put in the links both to the CDC Colorectal Cancer Control Program and to CPCRN. So thanks, Wynn, for that. So final question, and then we'll turn it back over to Sarah Bernal to close us up, is and open to anybody. What are you doing for those who do not have digital literacy and trying to navigate health education or telemedicine? So are there additional steps needed, recognizing that we've been making a lot of assumptions in terms of access to technology of late? Anyone want to?
And I don't think any of our projects were actually designed in the first place to depend upon digital access or digital literacy. And so the need to attend to that has been a feature of the transitions that have come from COVID. And I've heard more, for example, in Appalachia, about clinics themselves not even having the bandwidth to do video telemedicine, and certainly patients not being able to. I haven't heard yet anybody assuming that they're, for example, going to send out text that someone will receive and will understand. I'm not sure that has been a barrier yet for any of the access projects specifically.
Okay, yeah, and I think it does link, though, to a broader effort across the government around connected health and partnerships that NCI and others have had, you know, with FCC around building more of that infrastructure for broadband, which is in Appalachia, among other places as well. So with that, just want to say thank you, a huge thank you to our panelists for taking on a bunch of challenging questions. Thanks so much to everybody for giving us those questions.
Really good questions, yeah.
Go through, yeah, great questions. And let me turn it back to Sarah.
So I will echo David's thanks to our panelists and to David for their time today, and to all of you for these very challenging and interesting questions. That was fast and furious. So with that, I will remind everyone that an archive of today's session will be made available shortly on our website. You can join us for another webinar in November if you so choose, and we look forward to seeing you then. You may disconnect at this time. Thank you, everyone.
Thank you.